Good evening, all. We will discuss the rest, third part of the pre-implantation genetic testing or prenatal genetic testing. So, what are the basically the comparison of various screening method? Already I discussed all the screening methods. The first screening approach is your cell-free DNA. The second is first trimester screening, squad screening. The approximate gestational age range for screening is, the squad cell-free DNA, that is NIPT, has to be done from the 9 to 10 weeks to Tom's gestational age. The detection rate for trisomy 21 is 100%, almost 99 or 100%. The screen positive rate is 2 to 4%. Include enable to often result, which is associated with the increased risk. Highest detection rate can be performed at any gestational age after 9 to 10 weeks. The advantage is the lowest false positive rate. The disadvantages of the cell-free DNA NIPT test is the result may reflect underlying maternal aneuploidy of maternal disease. Several molecular methods is available. The first trimester screening, I told you has to start 10 to 13 plus 6 7 days. Detection rate 80 to 87%. Screen positive is 5%. Advantage is early screening, single time point test. The lower detection rate than test with first and second trimester component NT required. NT plus methods is NT plus PAP, pre-beta is alpha beta plus minus alpha beta variant. Card screen is 15 to 20 weeks, 22 weeks. 81% detection rate, 5% false positive rate. The single time point is no specialized required, low detection rate than first trimester, and first and second trimester combined is if you combine SCG, alpha beta protein, unconjugated estradiol, and inhibin A. Then if you combine all the tests, it can be integrated, it can be serum integrated, it can be sequential stepwise or contingent screening. Basically, you have to know what is this term is full integrated. What means by serum integrated? What mean by stepwise sequential? What is mean by contingent? Okay. So full integrated means you have to do NT scan plus PAPE, then followed by a quad test. This is full integrated. If you only do serum integrated, only do serum biochemical test, that is excluding the NT scan, that is PAPE and quad, that is called serum integrated. If you go by stepwise sequential, then if you first do NT plus dual marker, that is a combined test. If it is come as high risk, then CVS you will do, that is a stepwise sequential. If it is low risk, then you go to quad contingent test. If high intermediate risk and low risk, then you go for a second trimester screening. Comparison of integrated test, you done the same 10 to 13 plus 6, 10, 15, 20, 96% detection rate, high detection rate, 2 sample needed, no fast time result, NT required. NT plus PAPA, then quad screen. Serum integrated, only serum tested, detection is favorable, 88%. 2 sample needed, no fast time results. 6 stepwise sequential, 10, 13, 6, 15, 20 weeks. Fast time is provided, comparable performance is indicated. Contingent screening is 88 to 99%. The knuckle transplant alone is 70%, seen positive is 5%. The genetic sonogram, very important now. The genetic sonograms, the universal offers all patients, very important. You should offer all patients, should we offer a second trimester ultrasound to check the structural abnormality. What are the association with the trisomy 18 and 13 likely to measure structural anomalies? 21, only 27% so measure abnormalities. Soft sonography markers cannot diagnose or exclude trisomy 21 alone, should be interpreted with a full clinical context. Okay. So management based on the finding, single marker, if you have single soft markers, ultrasound sonography marker, that is if it is the echoseric cardiac focus or choroid plexus, you can offer an aneuploid screening, cell-free DNA or quad screening or amniocentesis. If you get a multiple soft marker present, then recommended genetic counseling, maternal fetal medicine center consultation needed. So if a single marker, you can also have a offer aneuploid screening, cell-free DNA, quad screening or amniocentesis, cell-free DNA, amniocentesis. If it's a multiple marker, then genetic screening and maternal fetal medicine consultation. Low risk in unpredicted result, no further risk assessment needed. Genetic sonogram, significant soft markers, that is high likelihood ratio, that is hyperechoic bowel. Nuchal fold thickness is more than 6 mm. Shortened humerus, shortened femur. So basically, you have to think about the bone and bowels and your knuckle and cardiac focus and renal. Basically all this kidney, heart, this is your kidney, heart, renal pylectasis, echogenic intracardiac focus, aberrant right subclavian artery, nasal bone absent or hypoplastic, ventricular. Basically you have to think about, if they are asking for soft marker, you have to look for 4 organs, that is renal, kidney, renal, heart, and your vessel, subclavian artery, the nasal bone, ventricle, brain, and your bone is humerus and femurs and the bowel. So basically if you compare these 4 names, like if it is soft markers, you can divide it by bowel, bone, then your heart, then your kidney, then brain. So 3 BHK you can remember by 3 BHK. Okay, you know 3, everybody is using 3 BHK nowadays. So 3 BHK is totally complete all soft marker. Okay, all soft marker, if they are asking all soft marker, 3 BHK in is bowel, hyperechoic bowel, then is a brain, that is your brain, you can ventriculomegaly, then is bone, you have two options, certain humerus, then echogenic kidney, echogenic heart, echogenic intracardiac focus in heart, then kidney is renal pylectasis. Then you can know all this knuckle translucency with more than thickness 6 mm, that is your, and nasal bone absent or hypoplastic. So very important, 3 BHK if you remember, then everything is possible by the remembering the all the soft marker you can easily tell in your Bible. Then soft marker with lower predictive likelihood ratio, 2 basal umbilical cord, coronary plexus seat, sandal gap on the foot, widened ischial spine in angles, hypoplasia of the mid phalanx of the fifth digit, short ear, short tibia, and short fibula. These are soft markers you have to remember. Okay, the management of ultrasound marker. Suppose you get an ultrasound marker for aneuploidy, what we will do next? Okay, ultrasounding marker for aneuploidy, like first marker, soft marker is the first trimester enlarged knuckle translucency. Imaging criteria, certified US measurement more than 3 mm above 99% of the CRL. Then aneuploidy association risk increase with size of NT associated with other structural anomaly genetic disorder. So you have to do genetic counseling, offer a diagnostic testing comprehensive US evaluation including detailed 18 to 20 weeks fetal targeted scan, fetal cardiac and 2D echo has to be done. Consider if NT is 3 to 3.4 mm is recommended, or if it is recommended if 3.4 or greater. Okay. Then if you get a cystic hygroma, large single multilocular fluid filled cavity in the knuckle regions can extend to the length of the fetus, 750% are aneuploidy. You will go over a genetic counseling, diagnosis testing, comprehensive US evaluations, comprehensive targeted fetal anomaly scans, fetal cardiac evaluation has to be done. Second trimester, thicken NT more than 6 mm from outer edge of the occipital bone, outer skin in midline, 15 to 20 weeks. Associated trisomy will be there. So detailed anatomy survey, genetic counseling, and testing should be offered if not previously performed. Second trimester, absent or hypoplastic nasal bone, non-visualization of the nasal bone or nasal hypoplasia based on the multiple of the modians, or percentiles or the biparietal diameter of nasal bone ratio, very race ethnicity, absent 30 to 40% fetus with trisomy 21.3 to 0.7 Euclid, hypoplastic is 50 to 60% fetus with trisomy 21 to 6. Digital anatomy survey has to be, genetic counseling and blood testing should be done. If you give a pylectasis, then renal pelvis measure more than 4 mm, anterior posterior diameter up to 20 weeks. Trisomy, if isolated finding, aneuploidy testing should be offered if not previously performed. Repeat ultrasound third trimester to assess the need of postnatal imaging. If a secondary trimester echogenic bile is there, then associated trisomy will be 21. Intraamniotic bleeding, CMV infection, FGR. So detailed anatomy survey, genetic counseling, offer CMV. So very important. If you get a echogenic bowel, what will do? CMV testing. Echogenic bowel. You can previously whatever I told, no. Previously all this like translucency, NT increase, cystic hygroma, NT scan increase. This is just you go for a targeted scan. But I show this is the very important, the bowel. Bowel in pylectasis you will go for. In pylectasis you will go for a third trimester ultrasound foot assess the anterior posterior diameter of the renal pelvis. But in echogenic bile you have to do a CMV infection testing and okay cystic fibrosis testing. Very important. CMV, cystic fibrosis in echogenic bowel. So growth scan also you have to do to determine the fetal growth restriction. Second trimester, mild to moderate ventriculomegaly, lateral ventricular arterial measurement 10 to 15 mm, association trajectory, detailed anatomy survey, genetic counseling. Here also you do CMV. So very important two statement, bowel and brain ventriculomegaly you go for a CMV testing, and for bowel cystic fibrosis has to be done. Okay, next question is short femur length. If less than 2.5 centiles, less than 2.5 centiles for gestational age, you can be associated aneuploidy, FGS, skeletal dysplasia, other genetic diagnosis. Aneuploidy testing should be offered, not previously performed. Consider repeat ultrasound in third trimester for fetal growth. Second trimester echogenic intercardiac focus. If second trimester echogenic intercardiac focus, then echogenic one or both ventricles of the heart in standard four chamber view. 50 to 30% fetus are trisomy 4 to 7 euploidy. So if you get isolated finding, aneuploidy screening is offered if not done previously. But described finding is not clinically significant as to normal variant with the normal screening. Then second one, choroid plexus cyst, discrete small cyst, one or both choroid plexus, seen as an isolated finding in 1 to 2% normal patients. All is associated 18, trisomy 18. Choroid plexus is very very important, trisomy 18. Remember all this we are asking about trisomy 21, but choroid plexus is basically choroid plexus is remember 18. Very very important. Basically other I told you 21. If you go with isolated finding, always remember if you get an isolated finding, only one choroid plexus, no other abnormality, then you go for an aneuploidy screening test. And discuss the finding is not clinically significant as a normal variant with normal screening also. Okay. So how to approach all this very very confusing test statement. So first step, you have to do search for the soft marker. If you are thinking some aneuploidy, if you get some defect or you, so first step is how to approach. First step, search the other soft markers structural abnormality in the fetus, including the fetal heart, cardiac. Step 2, calculate the risk of aneuploidy trisomy 21 based on the likelihood ratio against a background risk based on the maternal age alone or in combination first trimester screening, NT or maternal serum biochemistry. Suppose you get a soft markers, then you have to go by, you have to calculate the risk of aneuploidy, that is trisomy 21 based on the likelihood ratio against a background risk, like means that patient already have a maternal age and she have already NT scan, maternal serum biochemistry already has been done, that is a background risk, and second time is a maternal screening test. So step 3 is counseling, low risk, high risk, or low risk less than 1 is to 250, high risk 1 is more than 1 is to 250. For trisomy 1830, cutoff is 1 is to 100. So very very important, the cutoff is different for trisomy 21 and 18 and 13. 21 के लिए 1 is to 250 is the high risk, 1 is to 100 is the 18 to 30. Very very important. So prior risk and adjusted risk. Prior risk means background risk based on the maternal. Prior risk means she had already risk. Okay, she had already risk, like means suppose she had a maternal age and NT scan and the first time biochemical, second time biochemical screening is there. Based on that, she has a prior risk. Adjusted risk is prior risk into the factors derived from the screening test. So markers, intracardiac echogenic focus, the likelihood ratio is 5.83. Like LR isolated marker, ventriculomegaly, these are the increased knuckle flow, echogenic bile, mild hydronephrosis, short humerus, short femurs, aberrant right subclavian artery, absent hypoplastic nasal bone. These are the single markers seen in use LR for isolated marker. For example, 30-year primary prior risk at time of scan based on the age is 1 is to 1000 for DS Down syndrome. Isolated ARS at anomaly scan is likelihood is 3.99. So if you get a isolated marker, then you use the likelihood ratio. Okay. So calculated risk is 1000 by 3.9 is 256. So basically, if you, this is the case, single markers seen. If you are single marker, then use LR isolated marker. Suppose example 30-year primary risk at time of scan based on the age is 1 is to 1000 for DS. DS means years. Down syndrome, the age based on the age, the primary risk is 1 is to 1000, but isolated, she has a treated isolated aberrant right subclavian artery and anomaly scan. You have to, this is isolated risk, so you have to take a LR risk, that is 3.9. You can see this is a 3.9. So 1 is to 1000 divided by 3.9, the risk is 256. The calculated new risk is 1 is to 256. Now it is a high risk, just below, just going the high risk. The second case, there is a 30-year primary, very very important, listen this questions carefully. This is a 30-year primary risk at time of scan based on age, and first trimester screening is done 1 is to 10,000 for Down syndrome. So here the prior risk at time of scan based on the age. Before the anomaly scan, the prior risk is based on the age, and the NT scan based on the age and NT plus biochemical marker is 1 is to 10,000 for Down syndrome. At anomaly scan, we detected aberrant right subclavian artery and echogenic intracardiac foci. So new LR is calculated as follows. Here the LR is calculated. You have to, this is a not a single isolated marker, so you have to multiply the things. Okay. Here is a aberrant right subclavian artery is 21.48. So LR positive ratio, likelihood ratio of 21 for 4.8. For echogenic cardiac foci is the echogenic cardiac foci is 5.83. You have to multiply the risk 21.448 into 5.83. The risk is 125. Okay. The negative likelihood ratio multiply negative of all other markers. The negative will multiply the all other marker. Negative likelihood ratio will multiply it. Other marker like ventriculomegaly, increased knuckle fold, ecosinobial, mild hydronephrosis, short femurs and femurs is 0.16. The new likelihood ratio is positive likelihood ratio plus above likelihood ratios, that is 0.25 into the negative likelihood ratio is the 20. So now the risk for Down syndrome for this fetus is increased 20 times, that is divide 1000 divided by 20 is 500, 1 is to 500 the final adjusted risk. Okay, so very important, you can understand. So risk is reduced. So this is the example how you will calculate the adjusted risk based on your prior risk. You have to base a new likelihood ratio, positive likelihood ratio and negative likelihood ratio, have to multiply to get a new likelihood ratio. Then the total prior risk divided by the nuclear ratio is the adjusted risk. Case 3, if all soft markers are absent, confers a 7.7 fold reduction in the risk of trisomy 21. Background risk of trisomy 21 is 1 in 500. New likelihood risk example, background risk is 1 is to 5000. Likelihood ratio is reduced by 7.7 confers. The new risk is 1 is to 3850. So flowchart, screening summary. Lastly, we will get a summary. AOGD practice recommendation. This is the AOGD, All India Guideline of Delhi Society. So in this guideline, desirable screening protocol in the first trimester, antenatal screening first trimester you will do. Preliminary risk estimate using, you will do a first trimester biochemistry, biochemical, beta SSC and PAP-A. First trimester NT scan has to be done. Then if it is screen positive, that is high risk, that is if 1 is to more than 250, refer to a genetic or fetal medicine consultant. You can offer a NIPT or you can offer an invasive test directly. If it is screen positive, remember, if it is screen positive but it is intermediate risk, remember always intermediate risk is 1 is to 250 to 1 is to 500. But remember here it is for Down syndrome, risk is positive risk is 1 is to 250. If it is a Patau-Edwards syndrome, the risk is will be 1 is to 150. Refer to genetic or fetal medicine consultation. Consider contingent screening flow chart 2. Then if screen negative, low risk 1 is to less than 1500. Detailed sonographic evaluations has to be done 18 to 20 weeks like normal anomaly scan. Discharge from screening protocols. Routine antenatal follow has to be done. Then what will do in intermediate risk group, we will see. In the contingent screening in intermediate risk group, screen positive, intermediate risk, that is 1 is to 250 to 1 is to 1500. Refer for a genetic fetal medicine consultant. Consider contingent screening. Is integration of risk of first and second trimester serum analyte is possible? Yes. Calculate the new prior risk. If not possible, then offer a genetic sonogram, modify prior risk. If a final risk is 1 is to more than 1 is to 250, offer invasive or NIPT. With less than 150, discharge from screening protocols. NIPT also can be offered as a contingent test in intermediate risk group. If high risk, offer a invasive test. So basically the contingent test is your integration risk of first and second trimester serum analytes. If this serum analytes of first and second is available, then you go for analysis, you calculate the new prior risk. Then if it is not available, then you for a genetic ultrasounds, then modify prior risk you have to calculate. Okay, if it is the screen positive intermediate risk group, in that cases, then you got, if final risk is 1 is to 250, offer an invasive on NIPT or 250 discharge. Or you can NIPT can also be directly offered as a contingent test intermediate risk group. If high risk, then offer an invasive test. Then screening to be done for those women presenting the second trimester. The antenatal screening in second trimester, offer a quadruple test as a prior risk. Screen positive, it is high risk 1 is to 250. Refer to genetic fetal medicine consultation. Offer an NIPT invasive test. Screen negative, low risk 250 less than 1 to 250. Detail ultrasound 18 to 20 weeks. Discharge from screening protocol. Routine antenatal follow-up has to be done. If soft marker found on anomaly scan, they can be used to modify prior risk. If no biochemical marker done, suppose second trimester there is not done any biochemical markers, then genetic sonogram, modify prior risk, flowchart 3 has to be followed. So I repeat this case. If you have antenatal screening first trimester, preliminary risk estimating using your first trimester biochemistry or NT scan has to be used. Then if screen positive आ रहा है, biochemistry based on the biochemistry. Then refer to genetic fetal medicine consultation, NIPT or offer NIPT invasive testing has to be done. If screen is positive but intermediate is 1:250, 1:1500, refer to genetic fetal medicine consultations. Consider antigen screening if intermediate is. If screen is negative, detailed ultrasound has to be done like a normal fetal anomaly scan 18 to 20 weeks. Then discuss from screening protocol, routine and detailed follow-up has to be done. The contingent screening in intermediate risk group, refer to genetic fetal intermediate is the integration of first and second trimester serum is possible. If it is possible, then calculate the new priority risk. If not possible, then after a genetic sonogram, modify priority risk has to be done. If final is 1:250, more than 1:2, invasive testing and NIPT. If it less than 1:250, discuss from the screening protocol. Or you can go for a intermediate risk. You can directly go for a NIPT as a contingent test in intermediate risk group. If high risk, invasive test has to be done. Then in the flowchart 3, women present, those present with women second trimester offer a quadruple test. They doesn't have any row Michael done possible. A prior risk, already have a prior risk, screen positive. Then you go for a NIPT invasive test, screen negative, low risk, detailed sonography. This is from protocol. If soft markers found on anomaly scan, then it can be used as a modified prior risk. If no biochemical done or possible genetic sonogram has to be then modified prior risk has to be clear. So overall we concluded here the first trimester screening methods. Then we will go for a next session. So we will go for a diagnostic procedures, coronary variant sampling, amniocentesis. We will discuss. If you like this, please subscribe. Thank you.